Hello everybody, my name is Dr. Vilardi. Welcome to the weight loss seminar. Today we're going to be talking about weight loss surgery. Bariatric surgery entails a big team. Part of the team, myself, I'm originally from Peru, born and raised. I did my surgical training in Mount Sinai, and then I did a fellowship in laparoscopy and weight loss surgery. We have a psychologist and nutritionist team, which is mandatory for insurance purposes. We have a bariatric coordinator, as well as my medical assistants and insurance verification. And the most important part of the team is the patient, and that's you. Why? Because the patient is the ones that have to make all the sacrifices and the biggest and most important changes. The process usually starts with an initial visit where we do the history and physical of the patient. Then, depending on this and the policy of the patient, sometimes we do medical weight loss supervision. Then we move on to a pre-op visit and the surgery. After surgery, we do a post-op visit, and we strongly encourage patients to follow up with our support group. This is a testimonial. This is Robin's story. Can you relate? Here's what my life was like. Imagine picking up 3 50-pound bags of dog food and strap them to your body. Then try walking. It was difficult to even bend down and pick up my little girl. Now, I have the energy to play with my children, and I'm comforted knowing I'll be around when they grow up. You can write your own success story here like thousands of people do every year. In the past, obesity was seen as a weakness and failure of an individual. Diet and exercise were prescribed treatments, and weight loss surgery was viewed as dangerous and extreme. Today, obesity is considered a disease and the cause of many serious health conditions. Surgery has gained acceptance as a proven method to treat this problem, but surgical treatment is not for all patients. Eligibility must be determined. Let me explain a little bit more. What has changed between the past and the present? And there's two main things. Number one, technology. And with technology, I'm talking about laparoscopy and robotic surgery. Today, we're able to do many surgeries through very small incisions with very low complication rate and very high success rate. That's why bariatric surgery has gained so much acceptance over the last 20 years. Number two, insurance companies. Insurance companies know that if they help the patient lose the weight, on the long run, everybody will benefit, including the patient and the insurance companies. All insurance companies cover weight loss surgery. These are very important points. Number one, bariatric surgery is another tool. It's not the cure. It's the most powerful tool there is today for weight loss. Bariatric surgery will not eliminate the emotional desire to eat. And as with any surgery, bariatric surgery may present risks. Commitment to long-term lifestyle changes, including healthy and appropriate eating and exercise, is key to success. And you will hear me say this over and over because this is extremely important. Sometimes it doesn't matter what we do, what it's important, what the patient does. And you must quit smoking at least 2 months prior to having surgery. So who is a candidate for bariatric surgery or weight loss surgery? Everything is based on BMI or body mass index. Number one, if the patient's body mass index is at least 40, the patient meets criteria. Number two, if the patient's BMI is at least 35 to 39.9 and the patient suffers from one or more severely obesity-related health problems like diabetes, high blood pressure, sleep apnea, etc., they do meet criteria. These are the two main criteria. All patients need to be at least 18 years old and be prepared to attend regular follow-up sessions and make lifestyle changes. We strongly recommend patients to check the insurance policy. Different insurances have different requirements. Call your insurance company and ask them any questions that you may have. So as we were talking, who qualifies for weight loss surgery? This is based on BMI. Normal BMI is between 18.5 and 24.9. Overweight is considered between a BMI of 25 to 29.9. Obesity is over 30. Usually you have obesity class 1, which is BMI of 30 to 34.9. Obesity class 2, which is BMI from 35 to 39.9. And obesity class 3 or morbid obesity or extreme obesity, which is BMI over 40. Who qualifies for surgery? If the BMI is over 40 or if the patient's BMI between 35 and 39.9 with a comorbidity. The United States is the heaviest country in the world. If you have in consideration all the obese patients, it's about 36% of the population. If you include overweight patients, that it's about 67% of the US population. Obesity, as we know now, it's a systemic problem. It affects every single organ in your body. There's health implications, physical implications, psychological implications, social implications, and even economic and financial implications. Obesity as a systemic disease and a problem affects every single organ of your body. If we start on the top, in the brain, higher incidence of stroke and intracranial hypertension, higher incidence of cataract. In the lungs, higher incidence of hypoventilatory syndrome, higher incidence of sleep apnea, potential higher incidence of pulmonary hypertension. In the heart, higher incidence of heart attack and coronary heart disease, as well as high blood pressure and high cholesterol. In the liver, non-alcoholic fatty liver disease, where it takes you to steatosis and inflammation of the liver, which produces hepatitis and potentially cirrhosis. Number one cause of liver transplant today is fatty liver disease. Gallbladder, higher incidence of gallbladder stones. In the pancreas, higher incidence of pancreatitis, higher incidence of diabetes. There's a 42 times increase on the incidence of diabetes among patients with high BMI or BMI over 35. GYN problems like abnormal menses, infertility, polycystic ovarian syndrome, osteoarthritis or problems of the joints. This includes knee pains, hip pains, back pain. The body is not built to carry this much weight, and eventually with time, the joint gets wasted and gets bone on bone, and that's when the problems start. Some patients come here because they need knee replacements, but the orthopedic surgeon, usually they recommend patients to lose the weight before they move forward with surgery. We also have venous stasis or lower extremity swelling, lymphedema, skin problems, etc., etc. We know today among patients with higher BMI, there's a higher incidence of certain cancers, and this includes breast cancer, colon cancer, uterine cancer, things like that. Some of the psychological impacts of obesity include depression, low self-esteem, social isolation, uncomfortable in public, lack of intimacy, and decreased libido. Some of the physical implications of obesity are going to the movies, sitting on a bus or a theater, flying, using seat belts, playing and picking up children or their grandchildren, maintaining adequate hygiene, and buying stylish clothes. Social impacts of obesity, unfortunately still an acceptable form of social discrimination. Annual economic impact, over $700 in additional pharmacy costs. Business-wise, more than $12 billion for employee care, 5% of the total healthcare expense. National total cost, over $240 billion. On the left, we have a graph that shows how much a patient may spend a month depending on their BMI. A normal BMI, maybe $20 or less. Overweight, maybe up to $40. An obese patient, up to $80. The numbers don't matter. What matters is the trend. The higher the BMI, the more we tend to spend in the pharmacy. Diseases attributable to obesity and the relative risk of developing certain diseases over the next decade for men with a BMI over 35. And the big one here is diabetes mellitus type 2. Men with BMI over 35 have a 42 times chance of developing diabetes. Diabetes is also a systemic problem. We call it the silent killer. Even though your sugars may be under control, diabetes is still working inside. As a systemic disease, it affects most of our systems. Diabetes is number one cause of blindness, number one cause of renal failure, and number one cause of dialysis, number one cause of peripheral vascular disease. It's also associated with a higher incidence of myocardial infarction. In similar fashion, patients with high BMI are at a higher risk of developing high blood pressure, coronary heart disease, and stroke. This graph shows the relation between BMI and mortality. The relative risk at 100, with a BMI of 25 or normal. As you see, as the BMI goes higher, the relative risk of mortality goes up, and usually that is related to the comorbidities or medical problems that we acquire as our BMI goes up. This slide shows the long-term survival on bariatric patients before and after surgery. The red is patients before surgery and the blue is after surgery, and as you can see, the risk of death decreases significantly. There's an 89% reduction in risk of death over 5 years for those who pursue surgery. Bariatric surgery is the only specialty that has been able to prolong life up to 10 years. Weight loss strategies. What are we doing today to try to lose weight? And the most common thing we do is usually diets. We tried multiple diets. That's keto diet, South Beach diet, Jenny Craig, Weight Watchers, etc., etc. And this is a conservative approach. The failure rate is about 90%. On the other hand, we have bariatric surgery with lifestyle changes, including behavior modification, diet, portion control, and exercise. And the success rate is 85 to 90%. The most common surgical options. We have the lap band, the gastric sleeve, and the bypass. The lap band system, it's a restrictive and adjustable procedure. The gastric sleeve, it is restrictive and it's non-adjustable. And then we have the gastric bypass, which is restrictive and also gives you malabsorption. The adjustable gastric band or lap band. The way it works, this is a silicone band that goes around the neck of the stomach and has a catheter that is connected to a port. We put fluid in the port and the band closes and gives the patient restriction so it can limit the amount of food the patient can eat. We take fluid out and the band opens, taking away that restriction. Some of the advantages: low complication rate, low malnutrition risk, no dumping syndrome. It is adjustable, customized per patient. It is reversible. Patients can come back 10 years later and say, "Doc, can you take it out?" And we can do that laparoscopically. Very low short-term mortality. It is done laparoscopically. It is a satiety-inducing procedure, and the average patient does not need an overnight stay. Some disadvantages: slower weight loss compared to the bypass and the sleeve. Regular follow-up is critical for optimal results. We usually try to see our patients every 2 months at least, and it does require an implanted medical device. Some of the possible risks and complications of the gastric band includes risk associated with any surgery, including mortality of 0.05% or less, infection, nausea and vomiting, band slippage less than 2%. That means that the band migrates down on the body of the stomach. That can cause an obstruction and it may present with nausea and vomiting. What we do, we usually first have to remove the fluid. If the symptoms do not resolve, we usually have to do an upper GI study where the patient drinks some contrast and we take some x-rays and we're able to visualize or identify if there's a slippage or not. Erosion, less than 1% of the time. That means that the band erodes into the stomach. And the way to diagnose that is with an endoscopy. We go with a little camera down into the esophagus and see the band itself, if it has eroded or not. If it has, we have to take the band out. The gastric sleeve is a restrictive and non-adjustable procedure. What we do, we usually take about half to 3/4 of the stomach out. The highway is the same, so the patient eats and goes down into the esophagus, into a smaller stomach, and down into the small bowel. Some of the advantages is that the amount of weight loss approaches the gastric bypass. There's no intestinal rerouting. When we remove this part of the stomach, we remove the ghrelin receptors. It's also called the hunger hormone. When we take this piece out of the stomach, the ghrelin levels drop and the patient is not as hungry. Free of dumping syndrome, low complication rate. It is done laparoscopically or minimally invasive. It is a satiety-inducing procedure, no implantable device. Usually 3-year data shows that the weight loss is maintained, less frequent follow-ups, and today this is the most frequently performed bariatric surgery in the United States. Disadvantages: it is something permanent. Possible risk and complications of the sleeve: Even though the rate is very low, patients need to know. Mortality, less than 0.5%. Pulmonary embolism, 1 to 2%. That means forming clots potentially in your legs that may go to the lung. As a prevention, we give heparin or a blood thinner to all patients before surgery, and we keep them on blood thinners even after surgery to try to prevent this. We get patients out of bed and walking the same day of the procedure. Gastric leak, 1 to 2%. Post-op bleeding, 1 to 2%. Overall, the complication rate is very low, but they do exist. The bypass is a restrictive and malabsorptive procedure. We create a small pouch on the top of the stomach, and then we bring a limb of small bowel. What happens is the capacity of the stomach has been significantly decreased, and the food, after going into the stomach, goes into the small bowel and bypasses the liver and the pancreas, so the food does not get absorbed. It's the second most frequently performed bariatric procedure in the US. We do it laparoscopically and robotically, and you have a 60 to 80% excess weight loss after 2 years, with very low failure rate, and success is significantly affected by diet and exercise, like with any bariatric procedure. Risk of complications of the gastric bypass, again, very few, but they do exist. Post-op bleeding, less than 5%, anastomotic stricture, 5 to 10%, marginal ulcers, 2 to 5%, internal hernias, 2 to 4%, and potentially, since it's a malabsorptive procedure, protein, mineral, or vitamin malabsorption. Robotic gastric bypass. Why we do all our gastric bypass robotically? Because it's been proven to have lower complication rate. Mortality comparing to a national average versus robotic average is 0.09% robotic. Pulmonary embolism, 0.6% compared to 1 to 2%. Gastrointestinal leaks, 0.9% compared to 1 to 5%. We do all our gastric bypass robotically. Why? Because you have 3D visualization. The surgeon is in control. We have more precise suturing with lower complication rate and at the same cost. There's no additional cost for the patient whatsoever. All right, a little bit about the process, how the pre-op works and the requirements. Usually, we have to complete the office visits and physician weight loss supervision depending on the policy of the patient. Some patients need 3 or 6 months. Then all patients need a psychology evaluation as well as a nutrition evaluation. EGD, this is an endoscopy. We usually recommend it on all patients that are going to have a sleeve or a gastric bypass. Medical clearance, depending on the history of the patient. Some patients need only a medical clearance. Other patients may need a cardiac or a pulmonary evaluation, depending on the history of the patient. This is patient dependent. Then we put all patients on a pre-op diet. This is about a 2-week pre-op diet. The pre-op diet is a high protein diet. This is before the surgery. We want the patient to be able to lose as much weight as possible. This is also what they called a liver shrinking diet. The recovery time. For the lap band, the length of hospital stay, either outpatient or the patient may stay 1 night, depending on the medical problems. Days to normal activity, 5 to 7 days. Complete recovery, usually about 2 weeks. With a sleeve, patients stay 1 or 2 days in the hospital. Days to normal activity, 7 to 10 days. Recovery, about 2 weeks to 2.5 weeks. For the gastric bypass, length of hospital stay usually is 2 nights, maybe 3. Days to normal activity, 2 weeks to 2.5 weeks, and recovery about 3 weeks for the bypass. Percentage of medical comorbidities resolved, and this is one of my favorite slides. Type 2 diabetes, 95% resolution. High blood pressure, 92% resolution. Improve in cardiac function, 95%. Improve in osteoarthritis or joint pain, 82%. Sleep apnea, 0.75%. Stress incontinence, 87%. Improvement in reflux, up to 98%. High cholesterol, 97%. And this is why we do what we do. So surgical weight loss is affordable. We will work hard to get your surgery pre-approved with your insurance company. If your insurance company ultimately denies you, there are still affordable options. Over 40% of people undergoing surgery in the state of Florida are self-financed. If the patient's policy does not cover bariatric surgery, or if bariatric surgery is excluded, there are still options, and this is some of the surgical weight loss costs. The lap band is about $11,000, the gastric sleeve it's about $13,000, and the gastric bypass it's about $19,000. This is a bit more because it's a more elaborated surgery, and usually the patient stays an extra day in the hospital. All these fees include hospital, anesthesiologist, and surgeon's fee, as well as 3 months of follow-up visits. All insurance companies cover bariatric surgery. Not all policies cover bariatric surgery. There are some policies that exclude bariatric surgery. But review the coverage in your insurance policy, understand the appeal process, and coverage possibilities. Some insurance companies mandate 3 to 6 months of physician weight loss supervision before approving surgery, but you can speak to our office if you have any questions. Bariatric surgery is endorsed by many medical organizations, including Centers for Medicare and Medicaid Services, as well as the American Medical Association. Why Advanced Surgical and Weight Loss Institute? We have a comprehensive team approach, treating the whole patient, body, mind, and soul. We have experienced surgeons with advanced training in laparoscopy and robotic surgery. We're compassionate, highly trained operating room staff and anesthesiologists committed to your care and safety. We're devoted to the effective and sustained weight loss of each person. We do not have any hidden administrative or program fees. We treat patients the same way we would like to be treated because we care. We care for the patient as an individual. We understand what they're going through. We're devoted to their success on the short and on the long term. For us, it's very rewarding knowing that the patient that used to take over 20 medications a day, now they're off all their medications. When their primary care tells them you are cured from your diabetes, you don't have any more high blood pressure. When the patient comes back and tells us that they were able to go to rides with their grandkids or kids, all patients are like family to us. And when they succeed, that means that we did our job. And here's a real testimonial of one of our patients.
My whole adult life, from pretty much 18 on, I was overweight one way or another. Sometimes it was just a little bit, and I have done Weight Watchers a couple times, and I was able to lose it. But then I would put it right back on, and then some. And every time I lost the weight, every time I put it back on, I would put more back on. Before surgery, life was painful. Every day, pain. Disappointment because I couldn't do normal things. Or if I tried to do something normal, I couldn't do it like everybody else. I would get too winded or too sore, simple things. I heard about Dr. Velarde actually through my insurance. Everybody in his office is fantastic. They're all wonderful and very welcoming, and they don't make you feel ashamed or anything like that because of your weight. It's a battle, and they know that, and they're there to help you the whole way. My insurance required me to wait 6 months to get approval. I had to attend the seminar and have some testing done. I had to see a psychiatrist for an evaluation. I had to see the dietitian, which is right there in his office. I also had to lose weight along the way. Not only Dr. Velarde, but the insurance wants to see that you're committed to the process and that you're serious about it. And so I had to lose weight on my own prior to. About 9 months after surgery, I started attending the post-op bariatric meetings, which are once a month at the hospital. That's a lot of great information, and you get to see his other patients and meet with them and talk with them and see where everybody is along in their journey and compare how life is like after surgery. And that support is really fantastic. It's really great to talk to people who know exactly what you're going through. My highest weight ever was 302. When I went in for surgery that morning at the hospital, I weighed 237, and I have lost 100 pounds since surgery. And I have been able to maintain that weight for about a year now. Life after surgery is just amazing. I mean, I can't even begin to describe the transformation and what a different person I am now than I was. and I'm able to do everything that I set out to do. I do so much more now. I'm really, really active. Go to theme parks all the time, and I never have to worry about not fitting on a roller coaster, and do other crazy wild things that I just would never have dreamed of doing because I was always very self-conscious. I never had the confidence to do anything before. Now I have the confidence to do everything.
Thank you for watching the seminar. I hope this was helpful. So are you ready to lose weight and be fit for life? If you have any questions, do not hesitate to call my office. We're here for you.